paper or pages with you handy, and we'll start with this 52-year-old lady with a hip fracture. I'll give you time to read this, and we'll go over the coding in a minute. And of course, you should go over it systematic. So you go with the first P wave, and then the rate, and then the rhythm, the axis, and then look at the QRS complexes, the T waves, and then the intervals. And at that point, you should have a clear diagnosis in your mind. All right. And feel free to punch in or just write your comments on the chat box. So as most of you got this right, so we'll code this as a sinus rhythm because there is a P wave that is upright and preceding every QRS complex over the STT wave abnormalities. We'll code this as a prolonged QT interval. And as Dr. Najmuddin elaborated in his excellent lecture, how do we code and how to detect the long QT interval in the ECG. The final diagnosis here is probably hypocalcemia, keeping a hip fracture in mind, and the prolonged QT interval. Keep in mind that whenever you got a prolonged QT interval, it's not uncommon to have a tall or peaked T wave. So avoid coding a peak T wave if you have a prolonged QT interval. So this is it for the first case, and excellent, most of you got this right. So this is a prolonged QT interval. The classical teaching or just the quick guide to know if this is a prolonged QT or no is to see the large squares, and if the QT interval is more than 2 large squares, then you can code a prolonged QT interval easily. The other way is to divide the RR interval, and if the QT interval is more than the half of the RR interval, then this is a QT interval. Perfect. Let's go to the next one, and this is a 75-year-old gentleman with syncope. And of course, in the exam, you will have a short statement or a short stem about the ECG that you will see. So again, we'll go systematic through this. So we'll go with the rate and the rhythm, and then the axis, and then comment if you can see any P waves, and then the QRS complexes, the T waves, and then the intervals. And if you have any diagnosis in mind, you can keep it in mind and code it. Right, let's see the answers and go through this. So we're gonna code this as this is a sinus rhythm, and if you concentrate more, you will find an AV block that is the second degree AV block of a Mobitz type 2. And in addition, there is a right bundle branch block. So if you concentrate here, you will find the P waves that is before the QRS complexes. That are the P waves here and here, and if you concentrate here, this is the right bundle branch block morphology, and it is complete because it's wide. If you concentrate here, this is the drop beat, this is a P wave, and there is no QRS complexes after that. And how do we know it's Mobitz type 2 is to compare the PR interval before the drop and the PR interval after the drop, and if they're constant, then this is a second degree AV block Mobitz type 2. And of course, we have the gurus of the electrophysiology, Dr. Al-Ghamdi and Dr. Najmuddin. If you have any comment in this regard, you can feel free and comment on that. All right, next is a 67-year-old male with a chest pain, and let's go over this quickly. And again, we'll go systematic, the P wave or the rate, rhythm, and axis, and then the P wave, the QRS complexes, and then the T wave, and then the intervals. If you have a final diagnosis, you can code it at that point. And one thing that you should keep in mind in the exam is that there are 25 ECGs with the coding, but expect that you will see some of them straightforward and some of them are complicated, or the board exam ECGs. But don't panic if you see something that is really straightforward for the exam. That's like a gift for you to pump up your grades. So this should be a straightforward for the boards. So this is, we're gonna code this as a sinus tachycardia because there is a P wave. If you concentrate, there is a P wave, and this is sinus tachycardia. There is an AV block that is winky back because there is a drop beat and then the cycle starts again. There is a progressive prolongation of the PR interval until the drop, and then the cycle resume again. And this is an inferior myocardial infarction based on the ST segment elevation in the inferior leads and the reciprocal changes as well. So the thing, let's go back. The thing that I want to concentrate on for the boards is that if you face any patient with an ECG that is consistent with an inferior myocardial infarction, there are few things that you should keep in mind in that regard. The first is if there is a posterior extension or there is an RV infarction that is associated with an inferior ST elevation myocardial infarction. The second thing that you should keep in mind is that if there is any AV conduction block. And the third thing is that if there is any associated right or left bundle branch block as well. So keep that in mind if you face any patient with an acute inferior myocardial infarction. And in the boards, believe me, it's not going to be a straightforward acute inferior ST elevation myocardial infarction. There will be a complication that is associated with it. And we know that at this level, you all should know how to diagnose an inferior myocardial infarction, but the trick in the exam is, will you be able to diagnose the AV conduction that is related or associated with the inferior myocardial infarction, or the other complications like the posterior myocardial infarction extension or right ventricular extension. Excellent. Let's go over this 69-year-old gentleman on treatment of hypertension. And let's take a minute here and start coding and see if we can diagnose this. Right, perfect. So got some few answers that are right, and mashallah, yani your ECG diagnoses are in the right track. So we're gonna code this as an AV junctional rhythm or AV junctional tachycardia. Keep in mind, if you commit yourself to an AV junctional rhythm or AV junctional, you cannot code a sinus tachycardia or sinus bradycardia or a sinus rhythm, because both of them are contradicting themselves. So keep this in mind for the boards. And this is like a killing mistake in the ECG. If you code an AV junctional rhythm, then you cannot code a sinus rhythm. These are two distinct and two different features. And if you're going to code this, then the system will delete both answers. So keep this in mind. If you code an AV junctional, whether it's a junctional tachycardia or junctional bradycardia or junctional rhythm, then you cannot code a sinus bradycardia. And similarly, if you code a complete heart block, you cannot code a sinus as well. So keep this in mind, and this is the main reason I brought this ECG. I know this is like a bread and butter of the ECG, but keep this in mind for the boards, that if you find an AV junctional rhythm, immediately, if you code a sinus, then delete that. Or if you code a sinus, then don't commit yourself to the junctional rhythm as well. And on top of that, of course, there is an AV dissociation. If you concentrate, then you find that the RR interval are not constant, and this is an AV dissociation that is associated with the junctional rhythm as well. But perfect. I think most of you got the junctional rhythm right here. Okay. Now let's go over this 66-year-old gentleman with a chest pain and see if you can code this right or no. Again, let's have 30 seconds to see, and this should be an easy as well, but it has like a take-home message. And just to reassure everyone here that the technical problems that were faced in the previous exams in regards of the ECGs being unclear or cannot be zoomed in or zoomed out or rotated, or many aspects of the, most of them were technical, got improved in this board exam, and we should have no problems, inshallah, in the coding in this coming exam. Just keep in mind that time is, well, yeah, for the cardiology, time is muscle, but for the exam, time is an ECG as well. So this is, let's see the answers quickly before going. Perfect. Excellent, mashallah. Yeah, you got this right. All right. So most of you got this right. So the trick here is that you should code a sinus rhythm as well. If you concentrate, you will find an ST segment depression there, so you don't have to put this as a posterior myocardial infarction unless you're faced with an inferior ST segment elevation. But the presence of ST segment depression in this case tells you that there is a myocardial ischemia rather than an infarction, and those myocardial ischemia are very evident in the anterior, in the septal and the anterior and the lateral wall as well. So avoid coding this as a posterior myocardial infarction. This is an ischemia. If you find any depression or ST segment depression in the exams, so this is a myocardial ischemia until proven otherwise. If you find an ST segment depression, then it's either an ischemia or a reciprocal changes of an ST segment anywhere. So if you find no ST segment elevation in any other lead, then this is a clear ischemia. And once it's an ischemia, you cannot mistake that, because it has this ugly looking ST segment depression. And keep in mind that the ischemia comes in with the other things like a prolonged QT interval, or sometimes with an AV conduction, whether it's a first or second degree AV block. So ischemia has never been an ischemia by itself. It comes usually with either a prolonged interval somewhere or an AV conduction abnormality in other leads. But excellent, so you got this, but keep in mind that there is a prolonged QT interval on top of that. 43-year-old lady with an intermittent palpitations. Let's see if you got this. I think Dr. Khalid touched on this in the previous lecture. And let's see if you got this right or no. The chat box, yeah. Right. So, okay. So I got some correct answers and some of them, but always an arrhythmia. I think Dr. Najmuddin and Ben Rawandi will touch on the arrhythmia part in their ECG coding. There is a question mark. Okay. Now, we're going to code this as an atrial tachycardia and AV block with a 2-to-1. And the reason why we choose an atrial tachycardia is because if you concentrate on the P waves in lead V1 and the P waves in lead 3, you cannot really tell where is the P wave and if they're upright or inverted. So the presence of P waves in lead 1 and lead 2 is upright, but in lead 3 you find it isoelectric, and in lead V1 you find it negative. And that tells you that the firing is not from the sinus node or the AV node. There is an ectopic beat that causes an atrial tachycardia. The other thing is that there is a 2-to-1 AV block, and whenever you face an ECG with a rate that is 150 sharp, then you know that this is an atrial tachycardia with 2-to-1 AV block. And this is a classical ECG that always finds its way in the boards every year. That I would be surprised if there is a single board exam that has no atrial tachycardia with 2-to-1 AV block. So it's always in the exam, and it's similar to the other classical ECGs that you will find it, like a WVW or dextrocardia or limb bleed or lead reversal. So those are classical, and they're always showing themselves in the board exam. So this is an atrial tachycardia, and the atrial tachycardia is because of the rate that is 150 beats per minute sharp, or 140 to 150 beats per minute, and there is a multiple P waves before the QRS complexes and their 2-to-1 AV block. Excellent. So a 22-year-old lady came in for a routine examination. It should be easy for you guys. Let's have it 30 seconds before going into this, because we'll not spend much time in here. Perfect. Most of you got this right, and I'll take this chance before going. Okay. All right. So I'll take this chance and thank the people behind the scenes, the organizers, especially Dr. Abdullah Abdul Qadir, and the technical part of this, Mr. Hussam Dawood, for their tremendous work of putting this course together in a very professional way. So this is not a surprise for everyone. Just be careful coding this as a limb bleed reversal. This is a sinus rhythm, and this is a dextrocardia. And the features of dextrocardia, as you all know, is that the regression of the QRS complexes across the chest leads or the precordial leads from V1 to V6. So you will find a regression in the QRS complex amplitude, and in addition to that, you will find a positive QRS complex in AVR, and everything is like a mirror changes or a mirror image of a normal ECG. So this is a dextrocardia, as most of you or all of you got this right. A 67-year-old lady with palpitations, and we'll go through this. So this is like a professional level, and you expect to find similar ECGs in your board exam like this. Just be careful coding this and don't overcode things. All right. So, okay. Perfect. Excellent. Okay, so you got the sense that this is a bit advanced ECG, and this is like what you will expect to find in the board exam. So we're gonna code this one by one. So first you will find an atrial fibrillation, and the atrial fibrillation is because the RR interval is not constant. If you concentrate here, you will find a different RR intervals, especially after and before the premature ventricular contraction. So there is some sort of an irregularity in the ECGs, and of course we'll code the ventricular premature complexes based on these PVCs that in between the QRS complexes. And in addition, of course, as you all know, that there is a pacing or sharp signals here that indicates that there is a pacing biventricular devices there. And if you concentrate more, you will find it here right before the QRS complexes. So this is a biventricular pacing or a CRT in this ECG. So always don't panic and take things one by one. And I think I got some of the answers right. So this is an atrial fibrillation. There is a paced ventricular rhythm, and there is a premature ventricular complexes as well. And don't panic or overcode things. Once you got these, then believe me, the examiner wants you to just concentrate on these few things. Don't go over the ischemia or the other things, because this is what overcoding is. 21-year-old lady with a near syncope. And let's get this and see if you will get into the trap here or no. Right. As we receive the answers, I just want to say that I know most of you got the ECGs right. And my job here is to give you the tricks or the traps that some of the candidates will get into in the exam, and why they lose marks in the exam. So I know most of you will get this right. It's my job is to give you the roadmap, or to give you the tricks or hints or the things that most of the candidates will get into the trap from. Okay. Well, I'm not sure if there is in the coding exam, if there is an AVNRT or no, because they keep on changing the coding. But all right. Okay. So at least you didn't get into the trap here. So this is a supraventricular tachycardia, and if there is an AVRT or AVNRT in the coding sheet, then you should code this as an AV. You should code this as an AVNRT rather than VRT. So this is a supraventricular tachycardia of an AVNRT, because you cannot really see any P waves. But the most important thing here is not to code any STT wave changes of an ischemia only based on the ST segment depression that is associated with an SVT. You can code an ST segment abnormality or non-specific STT wave abnormalities, and that is the correct coding. If you find any STT wave abnormalities or depression, as in this case, but avoid coding an ischemia if it is associated with a supraventricular tachycardia or AVNRT. Even if you faced an ST segment elevation in the AVR or V1, or an ST segment depression in the lateral leads, keep in mind that those are expected once you get an AV NRT or AVRT of a fast rhythm or a fast rate like in this patient. So avoid coding an ST segment changes of ischemia only because there is an ST segment depression here. If you commit yourself of an SVT diagnosis or AV NRT or AVRT, then forget about the ischemia diagnosis. Okay, and I think this is my last, a 75-year-old lady with a dyspnea and cough. Let's go through this. Right, so we'll not spend time here because I'm sure Dr. Khalid commented on this in his previous. So this is a multifocal atrial tachycardia, as most of you got this right, because there are 3 different P-wave morphologies that you can distinctly see in this ECG. So if you concentrate, there are different P-wave morphologies here, and this is what all multifocal atrial tachycardia is. The last one is a 24-year-old lady with a non-Hodgkin lymphoma. Okay. Sorry, I think I had too much coffee and I pressed on the next unintentionally. So this is a sinus rhythm, and of course, if you concentrate on the rhythm strip at the end, so you will find an electrical alternance in there. Yeah, you got this right, of course. So okay, so you got this right. So there is an ST segment depression in here, but if you concentrate the lower rhythm strip, you will find that there is a clear electrical alternance in here, and the diagnosis is pericardial effusion, and you can, based on the ST segment depression as well, especially if you find a widespread ST segment elevation in other leads, you can code an acute pericarditis. But keep in mind, once you find a patient who got a cancer or a malignancy in the stem, keep in mind that it's either one of two. It's either a pericardial effusion or it's an electrolyte imbalance. So just keep that in mind for the board exam. So presence of a malignancy in the stem will tell you the diagnosis even before going into the ECG. But I think the diagnosis here was clear. How much time do I got left?